recently updated, 13 November. American Heart Association, American College of Cardiology, given update on diagnosis management of atrial fibrillation. So this is the highlight of 10 points. So what is the update? Previously it was 2014, 2019, and now 2023. Three updates they were given in atrial fibrillation. Apart from this, European Society of Cardiology also given the 2020 guideline. Now I am discussing what are the major things. So they give the stages of atrial fibrillation. Previously it was the chronic AF, long AF, valvular, non-valvular. Now they are giving the stage-wise like paroxysmal, persistent, long-standing, and permanent. This type of, and every stage is the treatment strategy are different. So they are focusing on the stages. Second point is the risk factor modification. This is the pillar of atrial fibrillation strategy because they are giving more weightage on this risk factor. Majority of cases there are underlying risk factor who precipitate there. So they are mainly focused to prevent or reduction of the risk factor. Third is the flexibility using the clinical risk score and expanded beyond the Chartwa score. Initially there was the Atrial score, Garland bleeding risk score, Chartwa score. Now they are given the extended clinical risk score. Initially they were given the intermediate or low probability. They are highly considered for oral anticoagulant for the prevention of thromboembolic risk. Now they are considered to reduce those risks so that further event we can reduce. And fourth is the consideration of stroke risk modification. So underlying risk we can modify. And then previously it was the rate versus rhythm, but now they clearly show that the rhythm is our first priority. Not immediate run into the rate control. Sixth point is the catheter ablation. Now it is the class 1 recommendation like tachycardia-induced cardiomyopathy, heart failure, any underlying WBW syndrome will precipitate to AF. So they are considering for young patient, athletes, HOCM. These are the class 1 indication for the catheter ablation. And seventh point is catheter ablation of AF in appropriate patient with heart failure with ejection fraction in class 1, as I already mentioned. Point 8 is recommendation have been updated for device detected AF. So device in situ, implanted device who detect AF, short run of AF either less than 5 minutes to 24 hours, more than 24 hours. So according to that and clinical risk score or bleeding risk score, we immediately start to anticoagulant for prevention of thromboembolic.
Catheter ablation is same as IF ablation? Same? Radio frequency?
Yes.
Same?
They are using the cryoablation.
Catheter ablation and radio frequency ablation is same?
Catheter ablation using the nitrogen oxide, minus 20, minus 40 temperature.
Same? IF ablation and catheter.
And another is left atrial appendage occlusion device receive higher level of class of recommendation because majority of time what happens, the bleeding risk is so much and the patient having the underlying prosthetic valve or the rheumatic moderate to severe stenosis. So these are the ideal candidates who have high risk of thromboembolism. So for that we cannot use very much aggressive anticoagulant or NOAC or warfarin. So for those people who are contraindication to anticoagulant, left atrial appendage is also upgrade from the 2A, which was previously 93. So next point 10, last is the recommendation are meant for patient AF identified during the medical illness or surgery, critical inpatient ICU to develop atrial fibrillation. So consider to this. These are the 10 points mainly they focus. So these are the objective classification, updates on diagnosis and management. These are the overview. Ablation, appendages occlusion, device detection of AF, anticoagulation, lifestyle and stages. So these are some incidents having, these are Western data, American College of Cardiology, they mainly focus the post-part USA 2050 and worldwide 50 million, having burden of very much majority of patients. These are the risk factors, some are modifiable, some are non-modifiable, some are cardiac, some are non-cardiac, some are genetical, or some are biological. So I am not going detail in this. Initially the stages they were mentioned 8 risk, underlying risk factor is there, they considered as at risk for AF, like modifiable or non-modifiable. Or pre-AF. Pre-AF in the either patient come, I detect the structural damage by echocardiography, like enlarged LA or any structural systolic diastolic dysfunction, or in ECG showing of atrial foci, multiple foci, having a past episode of atrial flutter. Majority of time this flutter degenerated to atrial fibrillation or other high-risk scenario. So again, these are the AF patient may transit among any of these group, like a paroxysmal AF, persistent AF, long-standing AF, or successful AF ablation. Previously it was not mentioned a successful AF ablation. So paroxysmal means within 7 days terminate. Persistent beyond the 7 days, and which required intervention, either pharmacological or electrical cardiology. Long-standing means more than 1 year. Successful ablation by intervention, this was the result. And permanent means do not attend either physician or clinician or patient combined decision, do not do any intervention for rhythm control. So these are the stages, and particular stages. Any one stage can degenerate into other stages, and we can treat according to this stage. So underlying modification risk factor is we have to monitor that cases. We have to risk assessment for stroke. We have to treat the underlying symptom, and we have to change the physiological. So mainly, basically, this pillar is mainly the risk factor burden of AF by rhythm rate control and risk, stroke risk assessment. So these are the previous
slide. I want to know this frequent atrial ectopy.
Frequent
atrial fibrillation risk factor. Yes. Frequent atrial ectopy. The activity measure beats the order regularly we find.
Yes.
So what is the further dissection of this?
So it is one of risk factors that will degenerate into precipitate like VPCs.
And what is the frequency level at which one should consider it as a pre-atrial fibrillation risk factor?
So we didn't give any those kind of ectopies.
Most of the time we consider atrial premature contraction is very benign.
So majority time maybe underlying factor either lung issues, COPD, or detect right atrial, left atrial.
So sir is asking in a normal person who is entirely normal, but somehow ECG કર્યો તો health checkup માટે કે pre employment માટે કે એમાં ATCs આવ્યા તો અત્યારે લગી આપણે અવગણતા હતા, but now you have put in a pre ACCS put. So does this require કે echo કરો કે બીજા કોઈ risk factor છે તો હજી કાંઈ evaluate કરો કે ના ભલે રહ્યા વાંધો નહીં.
So they given the guideline for
એટલે એ આગળ આવશે.
yes.
ચલો ઠીક. pre-react માં શું કરવાનું છે આગળ આવશે.
So these are the pillar for except to all aspects of care of all, like stroke risk reduction, optimization by risk factor modification, symptom management by decreasing the F burden, the rhythm rate control, by the shared decision making. So these are the mechanism, either coronary or non-coronary, by having left atrial fibrosis and lead to disruption of this channel, and these are autonomic system mediated adrenal gene. These are the genetical causes like TTA and MS6. These are association. And what is the barrier? They given some of barrier because less developed country, underprivileged region, less educated, low income woman. So shared decision making in the sense they decision regarding the whatever patient who need actually anticoagulant, decrease the symptom burden, or who need ablation. So these are the available decision aids for agency. So basic clinical evaluation, if a patient newly diagnosed AF or any underlying at-risk AF, they give some basic blood reports. Patient need to undergo some laboratory testing, metabolic panel, thyroid function, and then some echocardiography for detecting structural heart disease. They given the class of recommendation 1 and the level of evidence 2, but they say that there are no benefit of directly jump into the embolism or coronary artery disease, because majority of time either AF present alone or underlying coronary. If they mention that if etiology of AF, unless there is additional sign and symptom to indicate this disorder, then you go for coronary angiography or other imaging procedure. So these are the monitoring tool if underdiagnosed, undiagnosed is atrial fibrillation. So mainly the class 1 is the ECG or intracardiac signal detected by clinician for the diagnosis purpose, and class 2A is implantable cardiac monitor, which shows the rhythm or rate abnormality. So if non-case of atrial fibrillation, ECG or implantable cardiac monitor, the cardiac rhythm device will get read. So these are for the diagnosis purpose. These are the risk factors we can prevent. They mainly focus on the risk factor reduction: obesity, physical activity, hypertension, diabetes, smoking, and alcohol. So again, these are the risk factors. How we can modify the risk factor? We can decrease the weight loss, BMI more than 27, either 10% weight loss, reduce their symptoms, daily physical activity, or addiction, tobacco, alcohol, control the obstructive sleep apnea syndrome, minimize alcohol, caffeine abstinence, blood pressure control, regular checkup, and team approach. So again, in next slide they mention the risk score, CHARDA score, for those people who are prone to embolism.
So sir નો ક્વેશ્ચન હતો એ તમે બહુ સ્પીડમાં આન્સર આપી દીધો, એમાં બધું આવી ગયું કે ઇવેલ્યુએટ કરવું પડે, એવું કહેવા માંગે ને તમે?
Yes, yes.
Right? So if an ECG of a healthy person shows APCs, બરાબર, લોડ તમે કઈ સ્પેસિફિક નથી બોલ્યા, but he has to be evaluated. That is what according to you is there. કરશો તમે એવું?
Yes, definitely. First time detected.
આજે નીચે હેલ્થ ચેકઅપમાં કોઈ 35 વર્ષના ભાઈમાં ECG માં 3 APC આયા. Will you subject him for echo? It's not a part of health checkup, but will you advise activity?
Yes, yes.
You will advise. Okay. Point to be noted, sir.
Secondly, adding to CSI is another thing. Those patients who develop stroke and no obvious cause is found, from the even though ECG is normal, there are devices we can detect the predictability of atrial fibrillation in that patient, even though ECG is normal.
Device detected.
If you put that ECG into that software, they can detect that this patient might be having atrial fibrillation, even though apparently the ECG looks normal. I don't recollect that device.
So
that's what we
will discuss again in last slide of this. So again, this is the grading score. These are the additional risk factors for CHARDA score, apart from the CHARDA score, not including the CHARDA score. Burden F is higher, volume, diabetes, higher obesity, underlying risk factor. So these are the risk stratification to prevent a thromboembolic event into the atrial fibrillation. So mainly the CHARDA score we are considering for majority of patients, apart from this newer risk score is Atrial and Garfield F score. So what are the class 1 recommendation is that if a patient having AF, to evaluate the annual risk of thromboembolic by CHARDA score and evaluate factor which increase the high risk of bleeding. So the underlying risk factor we can control or prevent, it will decrease the further consequences. Those patients who have CHARDA score 1 in men or 2, it means the borderline or low probability of thromboembolism, benefit of anticoagulant consider for that. If high risk of stroke, then definitely we don't go for the CHARDA score and start the important anticoagulant. So these are the some published clinical score 2001 CHARDAS, Atrial, Garfield, and NCHADS. These are the online Garfield calculator, and bleeding risk we can assess with the Hasblad score, Hamlet or Atrial score. So what are the recommendation of antithrombotic therapy in atrial fibrillation? So firstly, for the antithrombotic therapy, they mainly said that the antithrombotic antiplatelet agent is not no more recommendation, either single or dual antiplatelet. We go for oral anticoagulant, either NOVA, preferably NOVA. If patient having a valvular or prosthetic valve or moderate to severe ARS, then go for the vitamin A oral antagonist. So annual risk stratification is class 1 indication. CHARDA score is more higher. Then anticoagulation is recommended for prevent of thromboembolism. If patient having no history of rheumatic MS mechanical heart valve, then direct oral anticoagulant, class 1 recommendation. And as I said, antiplatelet has no much of role. If intermediate.
So what is the level of recommendation of these two green?
Recommendation class 1.
Level of evidence.
Level of evidence is A.
1A.
Class 1 is a level of recommendation of Level of evidence A and recommendation of class is 1. So in a patient having intermediate risk score 1 to 2%, for that anticoagulation reasonable to prevent stroke or systemic thromboembolism is class 2A. And for those low risk, those without the risk factor, either aspirin monotherapy, either anticoagulant, no benefit, because we not those patients who regularly reassess annually and for scoring CHA score assess annually.
With most of the time, this atrial fibrillation more common in 75 years plus patient, most of the patient. Incidence is more. What is the recommendation of more than 75-year-old patient?
Share for the score.
For anticoagulant,
Yeah, what?
So any of phase is considered for is bleeding risk score and can give
એટલે ડિફરન્ટ નથી 75 પ્લસ માં સેમ છે 70 માં સેમ છે પેલા ચેટ વેક્સ માં જે આવે એ પ્રમાણે તમારે જોવા
Advance one factor is age. So more than 75 adds one score to the Chadwas.
નીચે અંડરલાઈન માં છે લખેલું છે સ્લાઇડ ની અંદર
Age more than 75 already used 2 point in Atrial, even in Chadwas it includes points. So age is a risk factor.
પ્રીવિયસ સ્લાઇડ જે પહેલાની હતી ને એમાં નીચે લખેલું છે એજ મોર ધેન 75 years.
એટલે what happens કે તમારું બ્લીડિંગ રિસ્ક થોડું ઇન્ક્રીઝ થઈ જાય એમાં એટલે એના અકોર્ડિંગલી તમારું ડોઝ કે બીજું કોઈ ચેન્જ થઈ શકે બટ ઇન્ડિકેશન છે તો ઇન્ડિકેશન રહેશે જ.
So again, this device detected, as you previously said, these slides suggest device detected atrial high rate of tachycardia, like patient having less than 5 minutes of episode, device showing that this is paroxysmal, no need to further anticoagulate this patient. If patient having between the 5 minutes to 24 hours, and if CHA score is high, more than 3, it may be reasonable to initiate the anticoagulant therapy. And if 24 hours episode, that means they are more prone to thromboembolize and high risk category. So directly start oral anticoagulant. These are the class 2A recommendation. And these are the silent AF and stroke of undetermined. Many of time patient present with TI or stroke and underlying risk factor we cannot identify. So those patients we have to intracardiac monitoring by blood and loop or any other device detector. So again, these are consider. These are the, again they say left atrial appendage occlusion device who have a previously it was not that much of class of evidence, but now they are giving the higher level of class of recommendation who are like contraindication or reasonable to stop oral anticoagulant therapy. Like this slide suggests percutaneously approach to occlude the left atrial appendage. This by mainly the Watchman occluder device and Lariat occluder device by percutaneously through transeptal puncture. So we consider the CHA score if more than 2. So there are 2 categories: patient having the contraindication to oral anticoagulant or either the bleeding risk is high. So those patients who have contraindication, we consider for the severe bleeding, severe intracranial, interspinal or serious bleeding when recurrent for infected deficiency, whatever the reason. And in patient who have more bleeding risk or oral anticoagulant, long-term anticoagulant is questionable. Then and then we can directly go with this occluder device. Another is cardiac surgery, left atrial appendage excision. In those patients who undergo CRVD or valvular surgery, at that time we are routinely doing here for transesophageal echostomy of left atrial upload. Then a patient undergoing surgery, then this strategy is useful. In patient with AF undergoing cardiac surgery with CHA score is more than 2, then surgical excision by removing the appendages and closure with stapler. So they said that apart from this excision, patient need anticoagulant for at least 3 to 6 weeks to high risk patient. And these are the bleeding risk if patient is on anticoagulant and what are the reversal agent and what are the bleeding risk. Like direct factor 10 beta fix 7, 7, there are class 1 for reversal agent and dexnate alpha, or these are the factor prothrombin complex concentration, or a patient having the dithrombin inhibitor, dabigatran, hydrasyluma, or a patient having warfarin toxicity higher and bleeding is there, that give for either vitamin K, IV, fresh frozen plasma, or platelet control. These are the slides showing the resumption if patient having ICS but high burden of like prosthetic valve, moderate to severe MS, or patient tendency to go with the thromboembolic risk. Then what are the mainly our concern and mainly our concern is that when and why we should start after the ICS to start the oral anticoagulant. If ICS there recurrent risk is low, then consider the Charva score, thromboembolic. Definitely Charva score is high because of the prosthetic valve. If high bleeding risk, directly go for left atrial appendage occlusion or either excision surgery, which was preferable. If low, then consider thromboembolic risk is very high, then we need to consider for the prevention of stroke, thromboembolic stroke. So early, within 1 to 2 is a class 2 recommendation for start, and those patients intermediate, less than 5% probability, we can wait up to the 4 to 6 week or 8 week, then start with the oral anticoagulant. These are the similar what I mentioned. So these are the timing of discontinuation with patient undergoing major operative changes, either abdominal or major operation. If there are chances of bleeding is higher and need to be more specific. So majority of high bleeding risk, they are the 2 days or low bleeding risk 1 day. Apart from warfarin, need to monitor the INR, and for this 5 days for high bleeding risk or 2 to 3 days if the INR is achieved. So these are the peri-procedural anticoagulation. So majority of physician refer to cardiac center for the patient having history of AF need to undergoing surgery. So what are the recommendations for that? If patient having invasive surgery, so they clearly said that if patient on direct oral anticoagulant therapy, then DOA action of onset is 2 or 4 hours. So need to stop either on the morning dose or hold, and no need to breathe therapy for that. Patient concern of the kidney function, concern of the bleeding risk and hemostasis after next day or the day after tomorrow. Apart from consider bleeding risk, heart we can use NOAA. But if patient on warfarin, if patient having prosthetic valve, high tendency of they need to breathing with repair. Otherwise, these are showing the breathing with LNW should not be administered except in patient with mechanical valve, recent stroke or history of TI. And again, a patient undergoing pacemaker or ICD implantation on patient of warfarin and risk is higher, more than 5%, then continue anticoagulation with not to interrupt. If the Charva score is higher, then either in an uninterrupted or interrupted, we can continue with that. So these are some specific conditions. Patient having AF, undergoing PCI, chronic coronary disease or peripheral artery disease. If patient undergoing ACR post stenting, so for that initial 1 week we can give triple regimen, dual antiplatelet, including P2Y12 receptor inhibitor plus oral anticoagulant. DOA, direct oral anticoagulant is preferable over their vitamin K antagonist. After 1 week to 1 year, with a single antiplatelet, preferably clopidogrel with NOAC, and then after 1 year, single antiplatelet is recommendation. If chronic coronary disease patient doesn't undergo any plastic, then oral anticoagulant monotherapy is recommended. For the peripheral artery disease, it is same. So what are the indications for anticoagulation in specific conditions like chronic kidney failure? Warfarin is not excreted by kidney. So these are the say desiccated stage 3, stage 4 or end stage renal disease dialysis. So warfarin is preferably with the risk score assessment, with the bleeding risk score. If valvular heart disease, if patient having rheumatic MS or moderately severe AF, there is no doubt to start with warfarin therapy. Doesn't count the Charva score because tendency of thromboembolic risk is high. So again now these are the rate control strategy. Initially they were given 7 to 18 rate is preferable, but now they say 110 heart rate is acceptable in resting condition. If patient undergo exertion, it may precipitate the underlying AF. So for those reasons, tachycardia-induced cardiomyopathy or heart failure or inappropriate, these all the burden underlying is reduced. So these are the rate control agents, either non-dihydropyridine, calcium channel blocker, beta blocker, amiodarone, digoxin, NGSO4. So what is our strategy of rate control as per this guideline? If patient acutely present, so firstly assess the hemodynamic stability. If it is unstable, then directly go for direct current cardioversion. Initially given 200 joule. If patient doesn't revert, then give higher energy of shock 380 or 360. If patient is hemodynamically stable, consider for patient having a history of ISD, history of heart failure, decompensated heart failure, structural division info. If no, then initial drug of choice is either beta blocker or calcium channel blocker to blocking the AV nodal pathway. And if it is ineffective, then go for digoxin. Digoxin mainly used for heart rate with reduced ejection fraction. And another option is amiodarone, is class 2 indication. Apart from the calcium channel blocker, magnesium, AV nodal blockage, maintains no calcium. So if decompensated heart failure is yes, then we all know that calcium channel blocker is not given. Even for those patients, rate control amiodarone is a useful strategy. So what are the long term for maintenance of if patient long term having reduced EF, we cannot give calcium channel blocker, beta blocker is preferably, but need to assess the underlying any COPD, any underlying hypertension disorder. So for those patients, we can either use digoxin or any alternate strategy. If EF is okay more than 55% non-thyroid calcium channel block, preferably verapamil or beta blocker and digoxin. If permanent AF, dronedarone we cannot use. Dronedarone mainly for the patient having scar on MRI, if patient having a history of ISD, because dronedarone mainly prolong the QT and precipitate the AF. So these are the recommendations for AV nodal ablation. These are those patients who are not reverted by repeated pharmacological and who require to undergoing ablation therapy. So these are the class 1 recommendation. So need to adjust the 1890 beats with pacemaker rate, and patient who refractory rate control medication doesn't respond for this, improve the quality of life for that purpose. On again, before the procedure, need to check if patient undergoing pacemaker implantation, need to check the lead and then AV nodal ablation and pacing value on his bundle and left bundle branch area. So rhythm control strategy, I will again go with this slide. So these are the goal of rhythm. Previously it was rate control, beta blocker, calcium channel blocker, if structural heart defect is not and EF is okay. Otherwise we can go with the digoxin or amiodarone. These are the rhythm control. Mainly they put more weightage on rhythm control. So don't rush onto the rate control if AF is nuanced. So if recent AF diagnosis, rhythm control is useful. So every word in this slide is they mention that rhythm control is superior because it reduces the tachycardia-induced cardiomyopathy, decrease the burden
Will you
of
confirm
AF.
that AF is contributing to the reduced LV function? That second category.
Now they are considered as ablation therapy.
Okay, but how will you confirm that AF is the contributing factor for reduced LVEF? How will you confirm it?
By past history or ecocardiogram. Otherwise,
A patient might be having underlying coronaries.
It is diagnosis of exclusion.
So you will go before attempting rhythm control, you will go for angiography or any coronary evaluation. In this patient, second category, reduced LV function and persistent AF, a trial of rhythm control recommended to evaluate if AF is contributing to reduced LV function. So you will just go for rhythm control directly or you will check first?
They don't mention patient need to
You have to mention where, yes or no?
Angiography is the
Sir, actually they are saying whether IDC or not IDC, if EF is less than 40, rhythm control is primary. It's primary.
And if
So
you want to
in a
confirm,
retrospect, after rhythm control, if your LV improves, then the AF was the contributing
yes,
factor.
it is diagnosing your
Is this like that? Okay. मतलब करी तो नाखवाना.
plus our
In
priority
first
is
year, there are multiple trials which are showing that the rhythm control is superior than the rate control.
Yeah, but more often than not, you are never sure of the duration.
majority of
yeah.
Right? Majority of time, you are not sure.
That's why they are first
So
detected.
it's a risky thing. If you take attempt and all these things, then there is no improvement. Patient ने तो भूखा बोले.
but again if we not control then chances
So भूखा तो बोलवाना चाहिए.
So these are the prevention of thromboembolism. It was previously also mentioned in 2014 90 guideline. So if a patient having more than 48 hours duration of day, 3 weeks of vital heparinase or therapeutic anticoagulation is necessary, then go for transesophageal echo for electrode, and then if electrode is there, again 6 weeks is mandatory repeat echo, and if patient having less than 48 hours, then they say the imaging to exclude intracardiac thrombus. Previously it was said that no need to transfer again echo if less than 4 because less tendency to formation of clot. So these are the electrical or pharmacological cardioversion. So assess the patient is stable hemodynamically, yes. Then electrical cardioversion is performed as initial rhythm control strategy. All the previous guidelines says if patient is hemodynamically stable, then pharmacological cardioversion can be. But these are they say electrical cardioversion can be performed as initial rhythm control strategy or after unsuccessful pharmacological intervention. Or any situation when pharmacological cardioversion is contraindication is not able to perform. So recommendation for pharmacological and electrical cardioversion. So if hemodynamically not stable, then directly go for electrical cardioversion. So what recommendation is that class 2A is utilized if patient having good LV function, IV utilized, class 2A is IV amiodarone, and class 2A is filling the pocket strategy. Patient hemodynamic stable outside the hospital, taken the flecainide or as one CAT arithmetic stuff. And after 30 minutes of beta blocker, and after 6 hours, if they reach the hospital and assess the patient, need to observe and admit those patients for 1 day. These are cleaning the pocket, but those patients who structurally normal have no any past history of ISD. And again, they use IV procainamide considered for alternative, any of these under contraindication. So what are the recommendation for electrical cardioversion? Electrical cardioversion, synchronize DC shock, low energy, with the QRS synchronization, because it may any type degenerate into VF. So for that, it is a class 1 recommendation. To electrical cardioversion, biphasic 200 joule initial. If a patient doesn't respond, the higher energy, patient is obese, then put a mechanical pressure. If patient doesn't respond, then give some propofenol or any drug will reduce the threshold of this cardioversion. So what are the anti-arrhythmic drugs for maintenance? If patient having AF, normal LV function, no any underlying structural or past history, then these are the 2A class of recommendation: flecainide, propofenol, ronidazole, dofetilide, and 2A is amiodarone, and 2B is sotalol. If patient having prior history of ILP, LV dysfunction, amiodarone and dofetilide, sotalol, majority of cases patient are underlying patient taking beta blocker or maybe. So that's why they are giving class 2B recommendation. And these are the reasons flecainide, propofenol, prolonged interval having recent MI precipitate the VT or VF, so they given the harmful in class 3 indication. If patient having NIDA class 3 or class 4 and having the repeated admission or heart failure, so ronidazole is not useful for those patients. So these are the slides suggestive of propofenol and flecainide to those patients who have no history of MI. Ronidazole those patients who do not underlying decompensated heart failure. Dofetilide is total effective maintenance sinus rhythm, but it precipitates the north side is the QT. So these are the duration of observation for fleck and acid in the pocket, ECG monitoring, and all this for drug monitoring, ECG mainly, and some of the creatinine. So again, this slide was on the catheter ablation. They showing that catheter ablation is now a patient who is symptomatic AF on antiarrhythmic drug have been ineffective, contraindication, not tolerate or not preferable, or rhythm control is achieved, then catheter ablation is class 1, level of evidence A. These are the updated. In selected patient, younger patient presenting with WP syndrome or AF or underlying some risk factor, then if patient undergoing EP study or RFA, then these are the catheter ablation need to be read for those patients. If patient symptomatically having atrial flutter, useful for those patients. If patient having ablation other than AF in the setting of arrhythmia, those are the indications. So they said the anticoagulation management before and after AF ablation. So we can continue with this anticoagulation now, and repairing we can continue with the INR mandate 2 or 3. And after ablation, 2 to 3 months mandatory for oral anticoagulant, and continuation of longer oral anticoagulant assess the Chadha score, risk score. So what are the heart failure patient presenting with AF? So mainly of patient guideline directed medical therapy, thromboembolism, prophylaxis, risk factor modification. If cardioversion is indicated, directly go for electrical pharmacological cardioversion. Need to rate control, rhythm control for those heart failure patient, rate control. If it is EF is less than 40, calcium channel blocker again is not indicated. Beta blocker is class 1, digoxin is beta blocker is we are not giving or intolerable. Digoxin and IV amiodarone we can use for rate control. If EF is good, beta blocker and calcium channel blocker, digoxin, amiodarone. These are the HFrEF patients undergoing taking anti-cardiomyopathy or whatever the reason reduce EF. These are the class 1 indication for catheter ablation. So for those patients need to rhythm control with catheter ablation. Who patient more likely to benefit? Previously, sir was asking those patients having AF reduce EF either because of AF lead to decrease EF. So for those patients, if benefit of catheter ablation, if patient initially present paroxysmal AF, minimum atrial fibrosis, or cardiac MRI showing the minimum scar, early stages of heart failure, younger patient, and AF-mediated cardiomyopathy suspect. These are patients likely to get more benefit. Apart from these, less likely to benefit for catheter ablation. For those patients undergoing catheter ablation, if patient is preserve ejection fraction, go for catheter ablation. Reduce ejection fraction, catheter ablation. If patient have a recurrent AF, then again repeat ablation. If a patient having no clinical sign of AF, just follow up this patient. If decision made on the pharmacological rate versus rhythm control, then pharmacological cardioversion, again they say dronedorone is neither class 3 or if patient is decompensated heart failure is contraindication. So again after catheter ablation, patient undergoing AF, pharmacological cardioversion, if patient having EF is less than 50, then after certain intervention, go with the AV nodal blocking ablation or pacing with the left bundle pacing. These are
catheter ablation. Our area size is not considered. That previously more than 4.5 centimeter size area involved, the success rates were less. But nowadays is not considered.
It is considered.
Because there is no mention of area size anywhere in your.
in one of slide 46.
That comes in the risk factor only. It is in the risk only. It doesn't decide outcome. It's a risk factor.
So that is class, now they will change the classification of things. That is class 1, that is risk factor 2.
LA volume more than 73 ml, LA diameter more than 4.7 was the risk. Okay, as soon as slide molecule. The volume of the molecule.
One of slide we mentioned.
The slide पूरी करना लिखता हुआ है.
Oh, the 100 slide is not.
पूरी खेती नहीं.
Yes.
એટલે સી તારો મેસેજ બધા મળી ગયો કે રિધમ કંટ્રોલ કરવાનો. એનથી વધારે તું શું બોલે છે તારા સિવાય લગભગ કોઈ નથી ખબર પડતી.
mainly focus on ablation, heavy nodal blocking, left atrial.
So maze surgery is now out of question. એક જમાનામાં મેઝ સર્જરી થતી ને પેલું સ્કાર it is obsolete, right? Okay, absolutely out of question.
Yes.
Right? Okay.
I think romantic valve surgery करता है atrial fibrillation हो एमा करता है.
They can go along with, but not independent. Along with they can. But again, now catheter ablation is evolved over a period of last 10 years. So catheter ablation is again preferable over this hospital surgery.
કેટલું બાકી છે હવે?
And rate. Focus on rate.
Part 1 part 2.
Rhythm.
હવે part 2.
Part 2.
એટલે બે પાંચ સ્લાઇડ તો પૂરી કરીએ બાકી.
Sir, this is like, easy back.
તું જે સ્પીડમાં જશે તો 2 મિનિટમાં બતાવી દે.
Those hundreds are covering one lecture. So again, these are the multiple underlying comorbidity, thyroid, pulmonary, CKD, obesity, athletes. So
આમાં કેવું છે દોસ્ત, આ એક વસ્તુ ડિસ્કશન વાળી છે. એટલે આ તો સ્પીડમાં જાય છે ને અમે સાંભળીએ છે, બાકી 100 સ્લાઇડ પોતે જોઈ.
આપણા રૂટીનમાં જ આવે છે એવું છે.
આ તારે 2 કે 3 પાર્ટમાં જ કરવી પડે ને એક પોઈન્ટ ડિસ્કસ કરવી છે. આમાં એક પોઈન્ટ ઉપર એટલા પ્રશ્ન આવે કે તારી પાસે જવાબ જ ના નીકળે.
Next time so